Welcome to the Shreds of Evidence podcast, where we look at evidence or the lack of evidence for the policies and the politics that shape the way paramedics deliver care throughout California. This podcast is proudly brought to you by Stanford Emergency Medicine and the California Paramedic Foundation, and is funded by a generous grant from the Bill and Christine Natick Foundation. My name is Mark Cotreau. I'm an emergency physician at Stanford and the EMS medical director. And with me in the studio today is John Earhart, a flight paramedic and a director at the California Paramedic Foundation. Hey, John, how are you today?
Hey, Mark, doing well. Glad to be in the studio with you.
Cool. Quick question for you. When you have that patient that you cannot ventilate and you cannot intubate, where do you go from there?
In California?
In California.
Oh, man. Not going to be doing a lot, I don't think, especially down in San Diego.
Yeah, it's a loaded question, but that's exactly what we're going to be talking about today. We'll be talking to Dr. Edward Damrose today. He's the chief of ENT surgery at Stanford University and is an expert on the subject of surgical airway.
Yeah, I'm super excited because, certainly we have our own bias in the pre-hospital space about what we should and shouldn't be able to do. So I think this is a great, neutral, obvious expert that can talk about, what this procedure is all about and if it's something that we should be considering. So maybe with that, we could start with just, the basics of this, like what are the indications for surgical airway in the view of Dr. Damrose?
I think it's indicated whenever there are patients that have evidence of upper airway obstruction, where there's concern that standard methods of intubation, endotracheal intubation, or placement of a supraglottic airway for ventilation may fail. And there are certain indicators of when that might be the case. If you have, for example, a patient who sustained anterior neck trauma, where you're suspecting perhaps a laryngeal fracture, that's a classic situation where one can anticipate there's going to be potentially devastating difficulty in trying to establish an airway from above. So in that situation, a surgical airway is almost always going to be your preferred method of approach to safely secure a patient's airway. Other situations that are coming up with greater frequency are the patients that have had, for example, radiation to the head and neck for head and neck cancers. And just as an aside, we're seeing an epidemic of HPV-related oropharyngeal cancer in younger and younger patients, those that never smoke or drank, where they may be getting radiation at a younger age. So there's great concern that this patient population that's had head and neck radiation will present a particular challenge for the endoscopist trying to actually intubate or access the airway. So those types of situations often are warning signs that a surgical airway may be necessary. And lastly, now that we are in this COVID era where we've had a number of patients undergo sustained prolonged endotracheal intubation, there's a greater uptick in airway stenosis that's being in this population, often months and months after they've been stabilized. And so some of these patients, no doubt, will likely need surgical airways simply because their airway is now so badly damaged that standard access by an endotracheal tube won't work.
So, John, we just heard some of the indications from Dr. Damrose. When should we be doing this in the field?
These patients are often really, sick and really, this is a life-saving procedure. And I think that's the interesting part about it. Like the indications for this are pretty clear and it's a standard of care. But in the flight community, the thing that we often have to teach people is just do it, right? Like you're at the end of a failed airway algorithm and this is a life-saving skill. And so you really have to nurture clinicians into a mindset of like, when we get here, we need to do this thing because it's that important.
And that's exactly right, John. The biggest reason for this to fail is actually timidity on the part of the rescuer. These aren't frequently done procedures. They aren't frequently needed. Most of the time we can intubate successfully, but there are patients for whom either because of trauma or cancer, their airway isn't standard. And our other rescue airway, the LMA, doesn't help us in these situations.
Yeah, there's some really clear examples from the flight community, obviously leaning very trauma heavy anecdotally from my experience. But these are scenarios where, you're talking about GSWs to the face or crush injuries, things that intubation or a King airway or an LMA aren't gonna resolve for you.
Absolutely. So the message here is when you have to do it fast. and do it with confidence.
Yes, work through your failed airway algorithm quickly and diligently. So I have a question, Mark, maybe we could discuss on the hospital side, because it sounds like the indications are clear and it's a standard of care for emergency departments and other specialties in this airway algorithm. Where is this happening in the hospital side? Is it mostly the emergency department?
This would happen mostly in the emergency department. These are time-sensitive procedures. You don't really have time to get the patient to the operating room. And that's an important point for paramedics to understand, is that we've heard that, from medical directors sometimes that, well, we're in a city, we're very close to our hospitals, we can just transport them to the emergency department for this procedure. But as you and I well know, if you're not breathing, that is truly a time when minutes matter. And there isn't the time to actually transport the patient to an emergency department in order to get this done.
The incidence appears to happen most frequently where trauma is encountered and where emergency medical services are most likely to be required. So to nobody's surprise, it's actually in the emergency department where this is most likely to occur. And studies show that where first responders may be most present, say flight nurses or paramedics, they're more likely to encounter this situation. The place where we are least likely to encounter the situation, paradoxically, is actually in the OR. But when you think about this for a moment, about how well trained our anesthesia colleagues are with the number of options and backup procedures available to them, it starts to make a little bit of sense. And then they're often thinking, or perhaps a little bit more prepared for the possibility of encountering the difficult airway. So in the OR, we're least likely to actually have to perform the procedure, and in our emergency departments, most likely.
What, in your opinion, is the reason that most attempts at this procedure fail?
Yeah, that's perfect question, Mark. In my opinion, it is unfamiliarity with the technique, unfamiliarity with the anatomy, unfortunately, lack of preparation, lack of anticipation that one might face a difficult airway, and then late recognition of the fact that one is indeed facing a difficult airway. Another, I think, in my opinion, a very large barrier is the perception that somehow a person performing a surgical airway is going to inflict tremendous harm or undue damage to a patient. And, as you recall from the courses that we teach, we try to emphasize that this is a absolutely life-saving maneuver. There really is not anything a person can do that will make things worse than what the patient is currently facing, which is impending death or brain death. And again, I think as a head and neck surgeon, I can tell you that much of the injuries that might be sustained, many of the injuries that might be sustained, essentially all of the injuries that might be sustained in a surgical airway, have a surgical solution that we can address after the fact once the patient is stabilized. So it is critical that people remove that barrier from their mind that they're somehow going to hurt this patient and make the situation worse than it is.
So that's interesting about how often clinicians balk at doing this procedure. I think one of the points to talk about is that this is a rare procedure. No one is going to have a tremendous amount of experience in doing this, and that includes physicians at a major trauma center. I can tell you that I've only done this a handful of times myself, twice as a paramedic before I even went to medical school, and only 2 other times in the past 25 years as a physician.
Yeah, I've only done it in a cadaver lab. Although I've had proximity to events, where it's occurred. I'm getting off shift and the crew before me has had to do that type of procedure.
Where do you think the fear lies?
I think that part of it is, it's the psychology of danger of doing a procedure like this. It's
the neck. I mean,
yeah, it feels like risk, and so that's the. I honestly, I can't speak for the ground side, right? Because I've only done this in the flight community, but there's a psychology to saying you are going to do this procedure that they've ingrained since day one, my experience in that, and saying, look, if you get to this point, you're going to do this thing. This is the standard of care, right? So you're going to mentally need to get over that. And then they reinforce it, to your point about it being a high risk, low utilization procedure. They reinforce that with practical skills, right? Cadaver labs, things that can show you that you can do this safely. And I think another thing on this is just-in-time education, right? Like having some rapid tools that are available just to make sure that you're hitting every step, right? As you're going through things, that somebody can work through a basic checklist or something as you're going through something.
How would you do a checklist? I mean, I would find it hard to do a checklist myself standing in front of a patient's not breathing.
So the way
you're talking about maybe on the way to the call, or
so the way that we do it for RSI, and again, it's a resource, right? And I think this is an important thing. It's not something that you require and say, hey, we're going to bottleneck you with this checklist. But if somebody's feeling less sure about a procedure, having a laminated checklist that you can hand to a firefighter, that's standing with you, or a captain at the door, to say, hey, I just want you to run through some check items with me, because obviously your hands are busy and bloody and you're doing things. And it's just a resource. That's the only thing I'm saying with it. I don't think it's something you mandate.
Absolutely. Anytime you can cognitively offload during a situation like this, the better.
Yeah. And then on the other end of that spectrum, you have the clinicians that are like, I've done 15 cadaver labs, 3 real world surgical crics, and I'm good to go, so.
Absolutely. Yeah. But I think one of the other points to remember here that Dr. Damrose mentioned is that this is a less dangerous procedure than most people assume. The front of the neck has very few structures that are going to get them into trouble. They're nowhere near the carotid arteries. They're nowhere near the big veins in the neck. And quite frankly, anything, as he said, anything that we break, he can fix, but only on live patients.
So maybe the next topic to discuss on this is just standardization of this, like simplicity. Yeah. Mark, What are your thoughts on, how you, with a low utilization, high risk procedure, how can you support success through just things like equipment and procedure process?
Yeah, I think that's correct, John. I think one of the magics of the procedure, as outlined by Dr. Damrose, is its simplicity. It uses equipment that is already available on every paramedic ambulance in the state. It doesn't require the purchase of new kits, and it means that paramedics can learn the procedure and practice the procedure using it the same way every time, no matter where they are, whether they change jobs and move from Los Angeles to San Diego or San Francisco or the Central Valley. Having a standard procedure that everyone uses and that has a very, very high success rate, I think, is a key to success here.
At Stanford, we tend to use the bougie-assisted cricothyrotomy technique. And the reason we came to that was for several reasons. One is that, again, when you look across, an enterprise this complex as ours, there's interestingly lack of standardization of available supplies, from, for example, from the emergency department, maybe a little different from the operating room, from the ICU. And many of these areas have certain pieces of equipment and resources available to them, but there's kind of a lack of standardization. And when you actually, you think about moving beyond our center and our enterprise out even further, you're going to see a greater lack of standardization. And secondly, the equipment that's available, for example, on a tracheotomy tray, if you were to call for a tracheotomy tray or a cricothyrotomy tray in an emergency, it is a bewildering display of equipment. It's great if you're an adept surgeon who's familiar with all of the equipment, but it can be, I think, incredibly daunting and confusing if you're not familiar with this, to the point that it may be detrimental. If you're struggling to search for a piece of equipment or recognize what is being put in front of you, that is not a good situation. And so when we considered what the literature had to tell us, simplicity of the technique and simplicity of the equipment needs seemed to be a critical element in being able to perform this procedure rapidly and efficiently. So therefore, we settled on the bougie-assisted cricothyrotomy technique, which really relies on 3 pieces of equipment: a scalpel, a bougie, and an endotracheal tube. And so most places, whether it's the emergency department, the operating room, or the ICU, will have access to these pieces of equipment, usually on a crash cart. And so that was one way to simplify the approach across a complex enterprise. The second issue is that it relies in many ways upon tactile feedback. So in other words, you're using your hands to guide the approach to the airway. Now, it may sound counterintuitive to think that might be better than using your eyes, but the truth of the matter is that with the distortion that takes place in the neck from trauma, or with one's unfamiliarity with the anatomy, being able to palpate is a critical step in performing the procedure, because one needs to localize the cricothyroid membrane, which may be actually difficult to do until you actually start to feel the neck and start to cut. So relying on palpation is a key feature of this technique. And again, another aspect we find that when one begins to cut on the anterior neck, it does bleed, and the blood can be daunting, and it can be distracting, and it can be a dissuader from having people move forward and complete the procedure successfully. So with the bougie assisted technique, palpation of the cricothyroid membrane occurs. There's sharp entry with a scalpel, at which point the bougie enters the airway. One can remove the sharps from the field, which is an important safety element as well. When you look at how many hands may be moving in and out of the field, the chaos that ensues. We don't want to see somebody have a self-inflicted knife injury to their own hand. So the knife leaves the field. And then even more importantly, at this point, that step has now established entry into the airway. And what remains is relatively simple: railroading the endotracheal tube over that bougie and into the airway. And we have now secured the airway. So with 3 instruments and a relatively simple step of procedures, an individual can perform a surgical airway and secure the airway. And these advantages are why we tend to emphasize this at our airway course, and why we promote this technique, because this is a skill that is rarely practiced and rarely utilized. But when it does need to be utilized, it's critical that we be proficient. My point of view, which may be somewhat controversial, is that I think we should be practicing this skill as often as, or at least as often as, we're being recertified in CPR and BLS. Perhaps that should be a station that accompanies something like the standard CPR station. The data of which I'm familiar seems to indicate that perhaps practicing the technique more often and revisiting the technique more often, perhaps every 6 months, may actually be necessary to maintain proficiency. But I think one needs to recognize the resources and the emphasis that is now currently placed on the technique, and perhaps set our sights on something where we're going from zero emphasis on performing the procedure, except in the rare events you might take a course like the one we've taught, where we handle the difficult airway, to perhaps approaching at least as frequently as we do CPR. Because to be frank, if you're unable to establish an airway, CPR, your efforts around CPR may be for naught. So it is an important skill to have and to revisit.
So that's super interesting. I really like this idea of considering, kind of to our point about psychology here, Mark, like considering surgical cric, which sounds like this really daunting, scary thing, but like pairing it with BLS skills, like you're doing CPR on a mannequin, but you're also practicing this skill because they're all life-saving. I just like that generally, 1, for the proficiency maintenance, but also 2, for the psychology of it, right? That's very interesting.
I totally agree. I think that one of the issues that we sometimes have in all of emergency medicine, whether it be in the hospital or in the EMS setting, is that we learn some skills and then we don't practice them often enough to maintain our proficiency or our comfort level with them. And so pairing it with CPR training or scheduling quarterly training, however a department feels that it's appropriate to maintain their proficiency in this, is critically important to both make sure that the muscle memory is maintained for that skill, but also that the psychological safety around actually being able to perform it when it's necessary is there.
Yeah. So in my experience, I have a question for you on this. So we've always done this in the flight community in cadaver labs. Those are annual, but the actual procedure, the surgical cric procedure training in that whole half-day event is very short. I mean, you're talking about each clinician spending maybe, 5 minutes practicing this, right? Because it's very straightforward procedure. It's really just kind of getting the initial pattern down, right? Exactly. But certainly you can't expect, large county operations to be doing cadaver labs, annually even, right? With all of their clinicians. So, from your perspective, maybe from, with your medical director cap on, how would you see that procedure being practiced or learned in the ground side?
Yeah, that is a difficult question to answer. We're seeing cadaver labs actually being used more and more for ground EMS. At Stanford, when we teach this procedure every year to all of the residents in surgery and anesthesia and emergency medicine, we're using pig tracheas, just the tracheas alone, that can be obtained at very low cost and are very, very easy to transport. Cadavers, of course, a lot of the cost of using cadavers is in the storage and transportation of the cadaver. In some jurisdictions now, we're using partial cadavers, just the basically diaphragm up, which requires much less in the way of embalming and formaldehyde, and allows them to be used over a period of a few days rather than just once. But there are another number of options, and I think as we develop better and better practice mannequins, this is going to become easier and easier to practice.
Yeah, I was going to say I have done the procedure practice with pig tracheas, and it is a pretty good representation of it. There's some ways to make it, seem more realistic for practicing, and then I think the mannequins are getting better and better, and there are mannequins that are specifically built for this practice, right? So there are some good solutions out there that are maybe lower cost and can still overcome that psychology and get that psychomotor memory down.
And that's the important part, is that yes, there is going to be variations in anatomy. And if you're doing this procedure, it's unlikely that the anatomy is really going to be perfect. But the point of the practice is to get that muscle memory down and to overcome that psychological barrier.
I think that, in your position, in the first responder world, I think I would ask you, do you see a pathway to how we can encourage our colleagues, paramedics, first responders, into being able to perform the technique, adopt the technique, and practice the technique? Because I think that, again, the impact that our colleagues can have in saving a life is paramount. Here in a hospital, we have an advantage in having an array of other specialists available and good equipment, as we discussed. But in the EMS world, I would say that, in the world of the first responder, getting that training out to them and encouraging people to do that seems to me like a daunting task. What do you see as a pathway forward there?
Mark, maybe as a clinician, I'm a little bit far removed from this discussion in this exact moment. So I have a similar question as Dr. Damrose. What are we doing for this? Because I can tell you from my perspective, and I think a lot of medics, feeling like your hands are tied in a really tough airway call is not a fun place to be, right? Having a skill that can be a little more definitive in, what I would call a landscape of failure, or everything preceding it, is a good thing. So why are, in the current environment where in the last few years we've taken away pediatric innovation, these other things, like why are we heading in that direction instead of working on things like this that haven't existed in this state?
Yeah, that's a great question, John. And coming from the East Coast, where this is much, much more frequently practiced, and in fact, I did some research in surgical airways and scope of practice in the vast majority of states in the United States, but not in California. And when I ask why, I get answers such as, the few cases have been failures. Very frequently, the tube ends up in the soft tissues anterior to the trachea and never makes it into the lumen of the airway. I think some of that is due to the attempted use of these packaged devices that are designed for more standard anatomy and not for the swollen, injured, and perhaps off-center anatomy that we find in the patients for whom this is indicated. So, and I think, as you well know, because of the difficulties California has had in maintaining truly great proficiency in the use of endotracheal intubation, there has been a tendency to pull back from advanced procedures, given the difficulty of keeping a vast paramedic workforce in California trained to very, very high levels of proficiency. I think that the methods outlined by Dr. Damrose, this bougie-assisted procedure, would go a long way toward helping overcome those barriers and getting this truly life-saving procedure into the hands of the rescuers who need it.
Really just so what I'm hearing you say is that the evidence is that this can be done safely, and it's done safely by a lot of states. I think it's an interesting discussion point is, as you reduce skills because you fear or we're risk averse to that, right? Or we're not able to train up people, or we feel like we can't train people up, that your metrics may get better, right? You may have less of these events. But I do recall being at a state meeting where a very wise medical director said, are we measuring the absence of these skills, right? In California, are we measuring the absence of having these? We don't have a metric for a failed surgical cric, but how many events are we measuring where that would have been an appropriate procedure and could have changed the course of it? So it's an interesting counterpoint to folks that are talking about reduction of skills in California.
And that's exactly right, John. It's very, very difficult to really put numbers on patients who would have benefited had they had this procedure available. Because let's face it, the only people who know are the medical examiners. These patients do not survive and therefore aren't typically studied. And let's face it, evidence is difficult to come by in a procedure that occurs so infrequently. When we talk about high quality evidence, we're usually talking about very large numbers, and we just simply don't have that here.
Well, I guess my last question for you, since you are on the commission and, have worked in MDAC for quite some time, is, let's say that there are medical directors that are supportive of this and counties that are supportive of this, and they feel like they could have the QA program and training program for this. Is the framework here? I know in other episodes we've talked about optional scope and how things would get done in this way. Is there a pathway here where, folks could kind of pull California back into the middle of the road? It would be cool to see California kind of rise back up to being, with the pack on some of these things.
Yeah, and absolutely, there is a path forward. And it really involves taking a proposal to MDAC and having MDAC recommend changes to the scope of practice to the EMS authority. Those proposals can be brought forward by any LEMSA medical director. And so once we have a LEMSA medical director who feels that they are ready for this, that they are confident in their training program, and can do this with a high degree of proficiency, then it could move forward. And I think that the atmosphere at MDAC is transitioning to a period where there'd be a lot more receptiveness to this.
Well, I really enjoyed this discussion. I think this is an incredible opportunity for California EMS, and I appreciate you bringing Dr. Damrose's expertise in for just some really good data points on some non-pre-hospital perspective on this. So thank you, Mark.
All right. Thank you, John.
Thank you all for listening to the Shreds of Evidence podcast, dedicated to exploring the science and politics of EMS practice in California. This podcast has been made possible by a grant from the Bill and Christy Natick Foundation, as well as the California Paramedic Foundation and the Department of Emergency Medicine at Stanford University.